Thank you. So we start by discussing treatment strategy for PTCL in the initial setting. Do I advance or? Oh, okay. So as you know, peripheral T-cell lymphoma are uncommon and heterogeneous disease. It represents about 5 to 10% of non-Hodgkin's lymphoma in Western countries. The most common threes are PTCL-NOS, angioimmunoblastic T-cell lymphoma, and anaplastic large cell lymphoma. The incidence is higher in Asia, and about 15 to 20%, where PTCL-NOS remains to be most common, but virally driven T-cell lymphoma such as NKT-CL and ATLL are more prevalent. The heterogeneity of disease reflect the diverse cell of origin and also genetic pathway that underlying lymphomagenesis. The WHO 2016 classifications begin to embed or incorporate some of those emergent genetic and molecular data in order to refine disease subtype definition. Examples include introduction of this follicular helper T-cell as cell of origin for AITL and subgroup of PTCL-NOS. The ALK-negative ALCL is now a distinct disease entity as opposed to be a provisional entity. There's also inclusion of a breast implant-associated ALCL as a provisional entity, amongst others. The inclusion of those genetic or precision medicine-based information has implications in terms of prognosis and treatment in both investigational as well as practical setting. For example, the ALK-negative ALCL, there's a subtype with DUSP22, IRF4 rearrangement, which tend to have favorable outcome, while the other subtype, which has TP63 rearrangement, tend to have worse prognosis where consolidation transplant may be advocated in the initial therapy settings. Subtypes of disease with follicular helper T-cell phenotype may have recurrent genetic mutations in genes including TET2, IDH2, DNMT3A. Those are genetic mutations that regulate epigenetic status. So one would postulate that agents that modifying those epigenetic process may have promising clinical applications in those conditions. And others, including hepatosplenic T-cell lymphoma, where the JAK-STAT mutation may be abundant. Something like JAK inhibitor may have therapeutic implications in clinical trials. So historically, outcome of T-cell lymphoma are inferior compared with the counterpart in B-cell. So with the exception of ALK-positive ALCL, the long-term clinical outcome of PTCL-NOS or AITL generally in the 30 to 40% range, which certainly speaks for substantial unmet clinical needs. One way of improving clinical outcome is to improve or optimize initial therapy clinical efficacy. So what do we do with initial treatment in PTCL? There's no standard treatment recommendations for PTCL, although the most commonly applied treatment is CHOEP chemotherapy. So in both prospective clinical trials or retrospective analysis, CHOEP chemotherapy provides an overall response rate of 60 to 80%. About half of them are complete remissions. Based on the retrospective analysis, there's no clear evidence to suggest that anthracycline is necessary. However, there's equally absent of evidence to provide a better alternative. So the current initial therapy, CHOEP remains to be a reference chemo backbone in this particular settings. So strategies to improve clinical outcome, especially in the frontline settings, involving several strategies, including adding to the CHOEP backbone, consideration of the frontline autologous stem cell transplant, and also moving novel agents into the frontline combinations. The evidence of benefit by adding etoposide to the CHOEP backbone are based on retrospective analysis. The best analysis coming from a pooled retrospective study which analyzed 7 trials from the German high-grade NHL study group, which included about 300 patients. In that particular analysis, majority of the patients had ALCL, some had PTCL, and AITL. The study showed that event-free survival seems to improve, but not overall survival. And another study, which is a population registry study from the Swedish registry, seems to support the benefit of PFS improvement in younger population, which is similar to this German study, younger patient with normal LDH and predominantly in ALCL subtype. The role of frontline autologous stem cell transplant has also been studied, and in single-arm prospective phase 2 study, as well as retrospective registry or population studies. There's no prospectively designed randomized phase 3 trials to analyze the outcome for patient either with or without autologous stem cell transplant. Therefore, patient selection remains to be a concern in data analysis. Nonetheless, if you look at the prospective phase 2 studies with autologous stem cell transplant, the progression-free survival 3 to 5 year range generally falls slightly below 50%, with overall survival around 50% for all comers. And for those patients that were analyzed in the retrospective registry or population studies, generally they are patient already went through this selection for transplant. The progression-free survival, 3 to 5 years, was in the range of about 60%, and overall survival falls about 70%. The relapse remains to be a main concern, even with frontline autologous stem cell transplant. One of the consensus coming out of all those analyses is that the response quality, especially complete remission status, remains to be an important determinator of clinical outcome. Therefore, achieving CR, improving the response duration, become important aspect of subsequent strategies, including incorporating novel agents into the frontline settings. And so we're coming to a more exciting chapter in terms of talking about frontline therapy in T-cell lymphoma. There are 4 agents that are FDA approved for relapsed PTCL that are being actively investigated of introducing into the frontline setting. The first is the anti-folate, pralotrexate. The second is the HDAC inhibitors, earlier with Romidepsin and more recently with belinostat. The third agent is an antibody-drug conjugate, Brentuximab, Vedotin, anti-CD30. There are other agents that are approved ex-US, which are listed here as well. So pralotrexate, as you know, is an anti-folate. It's provided intravenously weekly for 6 weeks with 1 week off. And in the registration pivotal studies, the overall response rate was about 30%, 29%, CR about 10%. And the common toxicities included mucositis and myelosuppression. Pralotrexate has been combined or introduced into the frontline setting with a combination of CEOP, where anthracycline was replaced by etoposide. The study was conducted with a T-cell Lymphoma Consortium out of Nebraska. In this phase 2 study, 33 patients were evaluated and receiving CEOP plus the pralatrexate, which was given weekly, 3 weeks in a row for a 6-week study cycle. The overall response rate was 70% with 52% CR, which was respectable. The progression-free survival, however, as you can see here, at 2 years was only about 34%, possibly reflecting toxicity, maybe also efficacy, durable efficacy, which did not meet the study endpoint. The next novel agent is Brentuximab Vedotin, which is provided as an infusion every 3 weeks at 1.8 milligram per kilogram. And in single-agent registration study, which is conducted in the systemic ALCL, this agent provides an overall survival of 86%, 57% of which was CR, which seems to be durable in the most recent update of the study population. That formed the base for the FDA approval in ALCL relapse setting. In experimental investigational setting, the Brentuximab Vedotin was also studied in CD30 positive PTCL as single agent. Overall response rate was 41%, 23% CR. Response seems to be higher in the AI-TL subtype. And based on that single-agent data, combination of Brentuximab Vedotin has been investigated together with CHOEP-based chemotherapy in the frontline setting. Phase 1 study was published a couple of years ago. The study was conducted either in combination fashion or sequential fashion. In the combination setting, vincristine was omitted from the CHOEP, so Brentuximab Vedotin together with CHP gives an overall response rate of 100%, 88% of which was CR, and a very nice progression-free survival of 71% in 1 year and 88% overall survival. This formed the base for the randomized phase 3 study known as ECHELON-2, where experimental Brentuximab Vedotin plus CHP combination was compared with the standard of CHOP chemotherapy. Patients were allowed to move on to autologous stem cell transplant following induction treatment if in clinical remission. This particular study has enrolled over 400 patients currently close to accrue and waiting for events analysis. So we're eagerly await for the study outcome to see if addition of anti-CD30 antibody-drug conjugate would translate the clinical efficacy in terms of response rate as well as progression-free survival. The next novel agent being combined with chemotherapy in the frontline setting is Histone Deacetylase inhibitor, particularly Romidepsin. As you know, there are 2 agents that are approved. Romidepsin is a selective HDAC inhibitor. Belinostat is a more pan-HDAC inhibitor. Both are IV agents, with Romidepsin provided weekly for 3 weeks in a row with 1 week of break, while Belinostat daily for 5 days every 3 weeks. Certainly there's more clinical experience with Romidepsin due to the longevity of this particular agent in the market. In registration studies, which are of very similar patient size, overall response rate, as you can see here, appears very similar, about 25, 26%, 10 to 15% CR, and durability of Romidepsin in those who can achieve response seems to be quite durable. The last update suggests over 2-year duration of response. As far as side effects are concerned, cytopenias seems to be milder in Belinostat, but certainly manageable with Romidepsin. So the combination of Romidepsin plus CHOP was studied in a phase 1B and 2 study that's conducted in Europe, CHOEP analysis. And study outcome was published about a couple of years ago as well. The recommended phase 2 dose of Romidepsin was 12 milligram per meter squared to be combined with CHOP on a weekly base for 2 doses. And the overall response rate for the combination was about 68%, CR 51%, which was respectable, and 18-month progression-free survival was 57%. This study, the combination and randomized study is moving forward, where CHOP was compared with a standard arm of CHOP, and that is currently ongoing in Europe, and results of that is also eagerly awaited. Another way of improving treatment efficacy or prolonging response duration is to provide maintenance, which can be done either following induction or consolidation transplant, or in some cases, perhaps right after induction for those who may not be able to move on to transplant. In this particular phase 2 study, Romidepsin is designed to provide to patients who received CHOP-based chemotherapy and moving on to autologous stem cell transplant. Following transplant, those in continued remission would move on to Romidepsin every other weeks for up to 2 years of treatment duration. It is currently ongoing at Cornell, Sloan Kettering, University of Washington, and Cornell, and which would provide evidence to support if maintenance following induction treatment would merit further investigation. So if chemotherapy may not be applicable to certain patient subgroups or may not work very well, what about using non-chemotherapy-based combination? So in fact, there is currently a phase 2 frontline study with a combination of Romidepsin and lenalidomide. Either of those agents are active in PTCL, and the feasibility of the combination was studied in a previous relapse refractory setting, and it was reported a couple of years back at Lugano. So this time it is in frontline setting, and lenalidomide was provided at full dose 25 milligram daily for 3 weeks with 1 week off, and Romidepsin was weekly dose with a ramp-up schedule starting at 7 milligram per meter square. And the primary objective is to study efficacy, and a secondary objective was to study safety and delay to cytotoxic chemotherapy. It is currently conducted out of Northwestern, and we're part of the study consortium. I just want to share some of our treatment experience with that particular frontline non-chemotherapy-based combination. One of the patients presented with extensive peripheral lymphadenopathy as well as cutaneous and subcutaneous lesions to the point where bilateral extremity swelling was profound, where patient could not even wear regular shoes. After one month of treatment, essentially all the cutaneous or subcutaneous lesions disappeared, and lymphadenopathy significantly improved. Patient was very pleased with the return of the skinny legs. In about 3 months, a very good PR was achieved, and by 6 months, nearly CR was documented by the imaging study. Side effects appears to be tolerable. They are a substantial amount of novel agents that are being evaluated in the T-cell lymphoma settings. And this particular slide's listed a few agents where we may have some preliminary data. Certainly it's not comprehensive or inclusive of everything that's being studied, that not reported. Some of those agents may look familiar as they are studied in B-cell histology as well. Others seems to be more specific for T-cell lymphoma. Those include anti-CCR4 antibody, 5-azacitidine, and crizotinib, amongst others. I just want to bring up a couple of agents, given their relevance in the frontline setting where investigations are ongoing of incorporating some of which into the frontline setting. One of them is lenalidomide, immunomodulatory agent with extensive experience in B-cell lymphoma. So phase 2 global trial with lenalidomide in PTCL was conducted in the EXPECT trial, where full dose 25 milligram of lenalidomide was provided daily, 3 weeks on, 1 week off. 54 patients enrolled. A significant amount of them were AITL, and the overall response rate was in the range of 20%, 11% CR. Duration for all comers remains to be brief in the single agent settings where cytopenias, myelosuppression are to be expected. So currently there is a frontline phase 1-2 dose escalation study incorporating lenalidomide into the CHOEP regimen for younger patients with relatively high-risk PTCL, nearly completing its accrual. So it would be interesting to see if combination would provide synergy in the frontline setting. The other agent is of interest where 5-azacitidine in the last ASH, there was a retrospective cohort report where it was given in the same dose as you would for MDS, which is at 75 milligram per meter square, daily, 7 days every 4 weeks. And the French group reported their experience in 19 patients with PTCL. Majority of them are relapse refractory with some concurrent MDS, CMML, where the 5-AZA was contemplated to begin with. And their overall response rate was reported at 53%, while particularly in the AITL population, 75% overall response rate and 42% CR was reported. Interestingly, when biomarker study was conducted to look at genetic mutations, TET2 expression, mutation expression seems to be correlating with sensitivity to this particular agent. This certainly provides an example of some of those precision medicine where those become compelling rationales to test subtypes with potential genetic susceptibility for certain agent. So the question for this discussion starts with what is the best initial therapy for PTCL? And majority of the discussion limits to nodal PTCL given the time restraints. The answer is we're still working on it, but I think it seems to be promising because now that we have more clues and also we have more tools because there are so many novel agents present and being investigated. To conclude, management for T-cell lymphoma remains to be challenging, and in frontline settings, CHOP appears to be inadequate as initial therapy for most of the subtypes. However, there's lack of evidence of better alternative. Addition of the etoposide and consolidation autologous stem cell transplant should be considered for younger, fit patients, especially those with non-ALCL higher risk. Novel agents, either alone or in combination, are being pursued, especially experience from relapse refractory settings are being applied into the frontline setting. So we're eagerly await several phase 3 data where additional evidence may be suggesting adding novel agents might be improving CR rate and response duration. We certainly would encourage more research with precision medicine, genetic analysis, and biomarker studies. And finally, as a community, that because of the rarity and diversity of our patient, education and advocacy for trial participation should always be encouraged. Thank you for your attention.